Hello guys, what's up today? I am MJ from Neurologic Research Center. Our research center work on multiple sclerosis. We wanna improve patient and doctor knowledge about this disease. During pandemic, MS patients are fearing from COVID-19 and it can due to a relapse. Today, we're gonna talk about a patient in Isfahan, Iran that can cured from that. COVID-19 infection in a patient with multiple sclerosis treated with fingolimod.
In December 2019, a novel coronavirus causing an infection respiratory disease was identified, which since then has developed into a pandemic, with higher rates of mortality in older individuals and those with underlying medicine condition.
Okay, MS or multiple sclerosis is an immune-mediated neurologic disease which requires long-term treatment with immune therapies that have been shown to increase the risk of infection. As a result, there is significant anxiety among patients and neurologists during the pandemic regarding the infection outcome in this patient.
And now we have a case presentation. A 42-year-old woman who was diagnosed with relapsing remitting MS in 2001 according to McDonald criteria and had been treated with methotrexate. 2 years discontinued because of elevated liver enzymes. Interferon beta 1a, 13 years discontinued because of disease activity and recently on fingolimod since 4 years. Presented with muscle ache, gait major depression, hypothyroidism, recurrent urinary tract infection, and history of pulmonary embolism on direct oral anticoagulation and myasthenia gravis. That diagnosed 5 years before MS and status after thymectomy. At her most recent follow-up in September 2019, her expanded disability status scale score was 1 for a positive Babinski sign on the right side. MRI was notable for moderate disease burden in the brain and the presence of 2 right-sided cervical cord lesions. Her lymphocyte count at this visit was 842.4 per microliter.
On March 1st, 2020, she started experiencing the symptoms that gradually worsened over the next few days. She sought medical attention on March 5 and was seen at the outpatient MS clinic. Neurologic examination relieved decreased sensation, reduced muscle strength, and bridge reflexes on the right and right positive Babinski sign.
These findings were consistent with new relapse or recrudescence of old symptoms. In another word, pseudo-exacerbation. She was then admitted for a relapse workup and treatment on the same day. On arrival, she was febrile with vital signs within normal limits. But initial laboratory investigation, were notable for C-reactive protein of 76 mg per liter and erythrocyte sedimentation rate of 46 mm, raising suspicions for an underlying infection etiology. Part of the infectious workup, chest X-ray showed a ground glass opacity, which raised a possibility of community-acquired pneumonia, for which she was started on azithromycin 500 mg daily because she is allergic to fluoroquinolone. On March 7, she developed dry cough, dyspnea, and fever. She also had tachycardia, increased respiratory rate, and a slight decrease in blood pressure and in oxygen saturation. with a decrease in lymphocyte count.
Fingolimod was stopped because of concern of sepsis. Ceftriaxone 1 gram twice daily was added and started on oxygen via a nasal cannula. Chest CT was performed to rule out pulmonary embolism, given her history. However, it was indicative of ground glass opacities. Given the clinical and imaging finding, COVID-19 was suspected, and a nasopharyngeal swab was obtained and sent to Isfahan University of Medical Science Reference Laboratory for real-time PCR testing. She was transferred to the special COVID ward and received a combination of hydroxychloroquine, oseltamivir, and piperacillin, whereas ceftriaxone and azithromycin were discontinued. 3 days later, on March 11th, she felt well and vital signs were stabilized, and she became afebrile and the lymphocyte count increased. On March 12th, the COVID-19 test was reported positive and all other medication except hydroxychloroquine were discontinued. The symptom of cough and dyspnea together with neurologic symptoms gradually improved. Finally, she was discharged after a 13 days admission and started on glatiramer acetate to avoid potential MS rebound after the discontinuation of fingolimod. Until the last visit, she has been self-quarantined at home with no respiratory or neurologic symptoms. But given that she did not get a new MRI during the admission because of hemodynamic instability and also testing positive for COVID, it remains unclear whether her neurologic symptoms were because of the new disease activity or worsening of pre-existing symptoms. In our patient, despite multiple comorbidities, the COVID-19 was resolved with good outcome and there was no need for ICU or intubation. As a result, pseudo-exacerbation or relapse without a clear etiology should prompt COVID-19 testing during the pandemic. Until next video, goodbye.